Reducing low value care in the Department of Critical Care Medicine, St Vincent's Hospital, Melbourne. St Vincent's Hospital Department of Critical Care Medicine is a 17-bed major tertiary referral centre with the capacity for 13 ICU beds and 4 HDU beds. As demand for critical care beds increase, so does the demand for all other acute service beds, resulting in critical care patients waiting longer for discharge to the ward. Despite these patients now being ready for ward-based care, the level of care often remains the same as they required when first admitted to the department. This translates into ongoing 1-to-1 or 1-to-2 nursing, regular blood gases, continuous cardiac and respiratory monitoring, and hourly documentation of these values. These interventions are unnecessary for the patient at this point in their care and can be prohibitive to their improving health and hinder their return to independence as their health improves. A multidisciplinary project team followed St Vincent's problem-solving framework to break down these issues and highlight focus areas where waste and unnecessary testing was occurring. The team decided to focus on unnecessary clinical observations resulting in continuous cardiac and respiratory monitoring and blood gas analysis on patients awaiting discharge to the ward. Other objectives for this project include improving teamwork within the department, enhancing patient experience, improving patient flow throughout the hospital, optimising nursing time, and reducing cost. A target of 60% reduction was set for blood gas analysis, with no patients in the department being excluded from the data. We set a 75% reduction for unnecessary clinical observations. However, we did exclude cardiac surgery patients from the data due to their current clinical pathway. A retrospective manual audit was carried out over a 6-month timeframe to ascertain the percentage of department patients that continue to receive an increased frequency of observations and blood gas analysis after being assessed as ward ready. The department's electronic medical records were utilised to obtain this data. The team then developed a standard for managing ward-ready patients. This standard included who was to be involved in the decision as to whether a patient was ready for the ward, when was this decision to be made, and how was this decision to then be communicated to the rest of the department. The ward-ready standard also indicated that once a patient was deemed ward-ready, all monitoring could be removed. An arterial line, if present, could also be removed. Blood gas analysis was only to be completed when clinically indicated, and a patient was only to receive 4 hourly observations, again unless clinically indicated. Through the engagement of the multidisciplinary team, the ward ready standard resulted in a 62% reduction in blood gas analysis and a 53% reduction in unnecessary clinical observations being carried out on patients whilst awaiting discharge. Staff in the department also noted that patients had an increased amount of independence and felt less dependent on nursing staff once the monitoring was removed. Morale amongst staff had improved, and the department's nursing staff felt that they had more time to provide support to colleagues within the department. St Vincent's Hospital, Melbourne is proud to be a Choosing Wisely Australia Champion Health Service.